Good morning, dear students. I'm Dr. Nanditha, reader from Department of Periodontics, here to share a small PPT on a very important topic in perio, that is diabetes and periodontitis. So, coming to diabetes, you all know what diabetes is, right? So, to definition of diabetes, it is a disease of metabolic dysregulation, primarily of carbohydrate metabolism, characterized by hyperglycemia. What is hyperglycemia? It is increase in the blood glucose level, and glycosuria, that is increased excretion of glucose in the urine, that is resulting from either a defect in the insulin production or secretion or action of insulin is impaired or a combination of both. So that is about the definition of diabetes mellitus. So how do you classify? World Health Organization has classified diabetes as two types. Basically, that is type 1 and type 2. Type 1 is also called as insulin dependent diabetes. That is, this type of diabetes is mainly seen in younger individuals. It is caused due to the destruction of the beta cells of the Langerhans, islets of Langerhans of the pancreas, which is the cells which produce insulin. And type 2 diabetes is basically seen in elderly individuals. It is not an insulin dependent diabetes. It is basically due to the resistance of the tissues to action of insulin. The insulin production may be normal, but the insulin action doesn't take place because of the resistance shown by the tissues. So we'll go a bit detail about these two types. So other than that, you have certain other specific types of diabetes and also gestation, that is diabetes seen during pregnancy. So what's the difference between type 1 and type 2? As I told, type 1 is insulin dependent. Type 2 is non-insulin dependent diabetes. Insulin dependent type 1 is mainly seen in children and younger individuals, and the prevalence is about 5 to 10%, whereas the most commonly seen type of diabetes is type 2, which is commonly seen in a middle-aged or elderly individual with prevalence 90 to 95%. And I said about the etiology, that is type 1 is because of the autoimmune destruction. It's an immune mediated type of diabetes because of the destruction of the insulin producing beta cells of islets of Langerhans in the pancreas, causing insulin deficiency. Whereas type 2 is because of resistance to the insulin action or impaired insulin secretion and increased glucose production in the liver. So type 1 is due to immune mediated, and type 2 is basically depending on the lifestyle factors and genetic predisposition of the patient. Symptoms in type 1 will be developing very rapidly, very quickly, whereas type 2 will be developing very slowly. So for us, from periodont point of view, we have very importance for diabetes because diabetes shows oral as well as periodontal manifestation. So first coming on to the oral manifestations or oral findings in a diabetic patient, you have kilos, you have drying of oral mucosa, cracking, burning mouth syndrome or burning mouth and burning tongue. It is because of the loss of papilla, depapillation of the tongue, diminished salivary production or reduction in the salivary flow, and alteration in the oral flora. That is, there will be greater predominance of Candida species, hemolytic streptococcus, and staphylococcus species. So these are the oral findings in a diabetic patient. Coming to the periodontal findings. Why periodontal changes are seen in diabetes? What all changes you see? So these I've already said about the oral symptoms. Other than that, an important symptom in a diabetic patient is polydipsia, polyuria, and polyphagia. Polydipsia means increased thirst. Polyuria means increased secretion or excretion of urine. And polyphagia is increased hunger. Okay, so these are very important. Polydipsia, polyuria, and polyphagia, which is seen in a diabetic patient. Other than that, you have delayed wound healing, etc. All these other symptoms. So we'll again move on to the periodontal manifestation. Periodontally, a diabetic patient has a number of changes in the gingiva. Okay, I'll give you an overview of that. Can you see the gingival changes? See the picture? You have the redness, the bulbiness, or the appearance of the thickening of the gingival tissue with redness, increased bleeding tendency, etc. So how do you explain the terms? You have enlarged gingiva. Basically, the gingiva shows inflammation or enlargement. Enlarged gingiva, sessile or pedungulated gingival polyps. Sessile and pedungulated. Sessile means without a stalk. Pedungulated is an enlargement having a stalk. Such gingival polyps will be seen. Then you have polypoidal proliferations of the gingival tissue. A very important or a classic sign in a diabetic patient is multiple periodontal abscess. You can just see the previous picture where multiple abscesses are seen on the gingiva. That is multiple periodontal abscess is a classic sign of a diabetic patient. Then finally, all these lead to periodontitis and loosening or mobility of the teeth. So studies have shown that uncontrolled or poorly controlled diabetic patients always have increased susceptibility to various periodontal infections. Most important is periodontitis. It was given by studies. And diabetes as such cannot cause gingivitis or periodontal pockets, but there are indications that the reasons for all these is the tissue response. Okay, the periodontal tissue response for a local factor like a plaque or a calculus will be hyper. There is increased response of the gingival and periodontal tissues to these local factors, because of which you have gingivitis, eventually leading to periodontal disease progression, periodontitis. So, what is the pathogenesis between periodontitis and diabetes? So you have following changes, that is changes in the bacterial pathogens. You have changes in the PMNs. You all know that PMNs are the first line of defense, polymorphonuclear leukocytes. And you also have very important change in the collagen metabolism. So we'll start with individual terms. First is bacterial pathogens. So studies have shown that as an experimental study done has shown that there is a total change in the subgingival bacterial flora to purely periodontal pathogenic flora with predominance of gram-negative cocci or gram-negative rods and filamentous organisms with deep periodontal pocket associated with deepening of periodontal pocket. And there is increased predominance of black pigmented species like P. gingivalis, Porphyromonas gingivalis, Prevotella intermedia, and Campylobacter rectus. So these are the bacterial changes what you see in diabetic patients with periodontitis. Next, neutrophil function. The neutrophil function, that is neutrophil chemotaxis, neutrophil phagocytosis, and adhesion is affected. The mechanism which has been suggested is inhibition of glycolytic pathway with the PMNs, abnormal cyclic nucleotide metabolism, which disrupts the organization of microtubules and microfilaments, or a reduction in the leukocyte membrane receptors. This is a mechanism which has been explained for impaired chemotaxis. Next, collagen metabolism. We all know that collagen is a basic protein which is present in the periodontium, gingiva, the PDL, the cementum, and the bone. So the collagen turnover is very important for maintaining integrity of these tissues. So you all know that in diabetic patients, you have formation of something called as AGE. What is AGE? Advanced glycation end products. So these AGEs go and bind with the collagen. Okay, and it makes it less soluble and less likely to be repaired. So what happens is the damaged collagen will be persisting in the tissue, which can easily break down in the presence of periodontal disease. That is how the collagen metabolism is affected in a diabetic patient, which can lead to periodontitis. So when the periodontal tissue collagen is damaged or it is broken down, it can further progress the severity, or it can further lead to increasing the or worsening the severity of periodontal disease or periodontitis. So these are three different pathogenic mechanisms. The role of bacterial pathogens, as you have said, predominance of gram-negative organisms and black pigmented species. Then the second mechanism is alteration in the neutrophil chemotaxis, phagocytosis, adhesion. And thirdly, alteration in the collagen metabolism. So these are the three different mechanisms of pathogenesis of periodontitis and diabetes. Now, if somebody asks you what a simple two-way relation, like how periodontitis increases the severity of diabetes, or severe diabetic or uncontrolled diabetes can worsen the periodontal situation. It is by this simple explanation is given by this pictorial representation. So we start with, imagine we start with periodontitis. Okay, a patient is having severe periodontal disease. So periodontitis is an inflammatory disease, we all know. So what happens when there is inflammation? There is increased production of these inflammatory mediators like your interleukins, your tumor necrosis factor, your prostaglandins, all these things. So these inflammatory mediators will go and bind, causing a resistance for the insulin action. Inflammatory mediators will cause tissue resistance to insulin action. even though insulin production is normal. Resistance for this insulin action will be because of the role of this inflammatory mediators. And once insulin resistance takes place, automatically patient develops type 2 diabetes. Now, how does the other way, diabetes to periodontitis? So, as we previously said about the collagen metabolism alteration, diabetes patients, AGE, advanced glycation end products, and other neutrophil dysregularities, etc. It will all affect the collagen. It goes and binds with the collagen. Along with that, the role of TNF, other inflammatory mediators. So collagen turnover. The damaged collagen will be persisting in the tissue. How? Because the collagen breakdown takes place. Turnover doesn't happen. So the weakened or less soluble collagen will be present in the tissue, which break down easily in the presence of mild inflammation. Thus, diabetes can increase the severity for periodontitis. So this is a simple two-way mechanism how diabetes and periodontitis is linked. Now, coming to the investigations, how do you know whether a patient is a diabetic patient or not? You have to basically carry out these lab procedures. Fasting blood glucose has to be checked, postprandial blood glucose, and something called as HbA1c. Fasting, this is the according to the American Diabetes Association standards, the normal, and a patient with diabetic, what are the variations? I'll go into detail on that. We shall just go to a diagnostic criteria for diabetes given according to Carranza. According to Carranza, it is said that a diabetic patient can be diagnosed by one of the three different laboratory methods. Okay, one is a patient having symptoms of diabetes plus a casual or non-fasting blood glucose level or plasma glucose level is more than or equal to 200 milligrams per deciliter. Secondly, and these patients also shows classic symptoms of polydipsia, polyuria, and polyphagia with unexplained weight loss. Fasting blood glucose or plasma glucose is more than or equal to 126 milligram per deciliter. Fasting means a patient should be on at least 8 hours of fasting. Okay. Thirdly, 2-hour postprandial glucose level, that is 2 hours after the food. The postprandial after the food glucose concentration levels is more than or equal to 200 milligrams. This is shown as per the oral glucose tolerance test. So how do you give this? You give a 75 grams of glucose orally to the patient, dissolving it in water, 2 hours after which you check the OGTT, glucose tolerance test. So this is given according to Carranza as per the data from the American Diabetic Association. So a patient shows a confirmation of these findings. You can confirm the patient as a diabetic patient. Now, I've told you something about HbA1c or glycated hemoglobin. It is a test which is done in a patient who is a known diabetic patient. And we want to check this past 6 to 8 weeks of diabetic control levels, for which we do the test. That is a glycosylated hemoglobin assay test. The normal values are 4 to 6% is normal, less than 7 is a good diabetic control, 7 to 8 is a moderate diabetic control. More than 8 means patient has to take measures to improve its diabetic level as per American Diabetic Association guidelines. So this test is always done in a known diabetic patient to check his blood glucose control over the past 6 to 8 weeks. Now, you've got a diabetic patient to you in the clinic. How do you treat? What are the guidelines you have to follow? Always ask the patient to get his glucometer at each appointment to test the blood glucose prior, especially when you're taking a long appointments. And if the glucose values are shown less than the normal, there are chances for patient going to hypoglycemia. That is less than, they said that 60 to 70 milligrams per deciliter. 4 ounces of juice has to be given pre-operatively as a safety precaution. Now, if the blood glucose level is excessively higher as shown in his recent values of HbA1c, okay, if we are going to do any extensive treatment, it has to be postponed. If procedure is lasting for hours, always check the blood glucose frequently in between to make sure patient doesn't go into hypoglycemia. Always hypoglycemia is a life-threatening condition than hyperglycemia. To avoid hypoglycemia, dental chairs treatments should be done on or after the peak insulin, that is just before or after the peak insulin activity period. Always have a knowledge on the pharmacokinetics of the drugs the patient is being taking. Normally, sulfonylureas or insulins, etc., are the drug of choice given for a diabetic patient. Thank you. With this, I wish to end the topic. The topic is very important.